Hi, everyone. This is Caroline from Fiat Integrative Health in Franklin, Tennessee, and you're listening to the Fiat Health Podcast. We believe that now more than ever, the healthcare industry has become a place of confusion. And over the years, we have been asked countless questions about what true health and integration for the whole person looks like. Join us every other week as we explore topics ranging from primary care and women's health to counseling and spiritual health. We're so glad you're here. Hey, everybody. Welcome back to the Fiat Health Podcast. My name is Caroline. I'm a family nurse practitioner and founder of Fiat Integrative Health. And today I am joined by Sarah. How are you today, Sarah?
I'm doing well, although recovering from a slight cold.
Yeah, I think we're both a little under the weather, so you may hear some sniffles and throat clearing, but we're gonna work through it. It's gonna be great. So Sarah, tell us, Sarah newly joined Fiat here. I can't say newly. She's been with us for what?
Since last July.
Yeah, a while now, actually, just on a very, very part-time basis. And we're really excited to have her joining our team on a more full-time basis over the next couple months here. And yeah, we're going to talk all about today what Sarah does and the patient population that she helps out with, and it's going to be great. So we'll jump right in. Give us a little bit of an introduction, Sarah. Tell us who you are, where you come from, why you got into medicine, all the fun things.
Yeah, well, me and my family are actually transplants to Nashville, like most people these days. We originally grew up in the Midwest in a very functional medicine-oriented culture.
Oh, interesting. Was it South Dakota, right?
Yes, Sioux Falls, South Dakota.
Okay.
And
I can hear it in your accent just a little bit.
Especially in the O's. We say Minnesota. Yeah, we go a little bit towards the Canadian accent. But we were really tired of the winters. So we migrated here about 3 years ago. I will say the weather is lovely.
Yeah.
I haven't met a bad weather day in Nashville yet.
Oh, that's awesome.
Looking for job opportunities and absolutely loving the outdoors. Me and my husband, we have one son, expecting our second in December.
Yay.
2 golden retrievers. They keep us very busy.
Aww.
Flock of 10 chickens. Lots and lots of eggs.
Yeah, that's awesome. So tell us a little bit about why you originally got into medicine, some of your training and job experience.
Yeah, well, like I said, I was raised in a very health-rich culture. Everyone was very health-oriented. Organic was, the way most of our friends ate. And also, I had a lot of exposure very early on to natural family planning and just what a window into your true health that was. I had a lot of health issues as a child, which through my own health journey, I've actually had almost complete resolution. So I wanted to share that with other people.
And so you kind of had this journey in your childhood that probably piqued your interest in medicine to begin with. And then did you jump right into I'm going to go to NP school, nursing school, or because I became a nurse, I went through a 4-year program and said I would never, ever in a million years go back to school. And I eventually did, obviously. But what was your journey there?
Yeah. So truly, I wanted to be a midwife. I'm the oldest of 12, and I was able to walk beside my mom through many, many pregnancies. I was inspired by ultrasound very early on, and I was very anxious to attend all of her OB appointments just to see that window into a woman's body.
Yeah.
And so I started out going to nursing school with that kind of in mind as the backup plan. But I was super happy just being a nurse. It really was kind of the similar, but I was working very pregnancy support center on a volunteer basis through school. And I began to just form these bonds with all of the women that were coming through education on their bodies, and realize that when you form relationships with people, you actually uncover deep health information. And so school was the natural way to bring more resources to those women. So I did go back, not for midwifery, because catching babies all night long is really hard with a young child, but as a women's health nurse practitioner. So I still have that focus just on women's health and the hormones, but work mainly in a clinic basis.
Yeah, it's a really interesting degree because it's, like women's health. It's very focused in on that. You can't see men outside of reproductive health. You can't see kids, it's not family medicine. It is, your training is very specific. And I think that's really interesting and great. Tell us a little bit about your background with hormones and, perimenopause and menopause and kind of what interested you in that and what you're doing here at Fiat.
Yeah. So during my training, one of the benefits of the Women's Health Program is that all of your clinical rotations do revolve around women. So I had a very rich experience throughout the Midwest, training both in a birth center and primary rural health centers, and then also at the Pope Paul VI Institute, which focuses primarily on hormones and NAPRO technology and hormone imbalances. So that was kind of my deep dive and introduction into the hormone health world.
And then you went on to work with pregnant women.
Yep.
Right?
My first job out of school was working with high-risk women. I've done that for about 3.5 years, seeing a lot of gestational diabetes, high blood pressure disorders in pregnancy, recurrent miscarriage. And then really it's been amazing because you see a much more advanced population than is typical for nurse practitioners because I worked directly with a physician. So I was able to see both lower risk gestational diabetes and also help assist with the care of very medically advanced patients.
Mm-hmm. And then what really triggered your desire to dive into perimenopause, menopause? Because you're caring for really high-risk pregnant women. And you're like, I think I'll just go get training and really dive into this population, right?
Yeah. So one of my preceptors in school introduced me to especially the perimenopause world because this was 2020, 2021. This was before kind of this revolution had happened in this middle-aged women's space, and there were just no options. And so I was exposed to the very beginnings of treatment with hormone therapy as it was just beginning to grow. And my preceptor herself was entering that stage of life, and she introduced me to the need. At the same time, I just began being approached by women, often women that I had known growing up my parents' age, as they began going through this stage themselves and having questions and concerns. And actually, it is an amazing foundation as the understanding of what starts to change because these are all your reproductive hormones aimed at supporting pregnancy. So what they are doing as they change as you are leaving that phase of life is very important to know and understand. So it was actually the women themselves that directed me into seeking for more and more information, the most up-to-date information to give at the beginning to my friends and educators who supported me growing up.
That's awesome. So I will readily admit that perimenopause and menopause is not my first love. And I know things about it, but I would not say I'm anywhere near an expert about it. So I would love to hear from you. Give us kind of the basics, like what is happening in perimenopause? What is happening in menopause? How do I know I'm in perimenopause? How do I know I'm in menopause? And really what's going on in the body?
Yes, I'm sure your listeners are pretty familiar with the basics of the menstrual cycle. At the beginning of the menstrual cycle, called the follicular phase, your entire body is oriented towards producing a high-quality egg. You need several signaling hormones from the brain. The main one that comes up in perimenopause and menopause is FSH, which talks to your ovaries and says, hey, let's develop an egg. And as this egg develops, it produces lots and lots of estrogen that helps support the growth. Then you ovulate, and that egg itself and the corpus luteum supports all of this progesterone, which is incredibly important for how a woman feels. The estrogen is also surging. And then if no pregnancy occurs, all those hormones kind of fall off. You might not feel the best, and the whole cycle starts over. What happens as you enter perimenopause is this ovaries become just less sensitive. They are trying to produce the egg, but you have less follicles, less eggs left. So the FSH is saying, hey, ovaries, can we get some eggs here? And the ovaries say, I'm trying. Okay. Oh, here, I found one. And then you'll get this surge. The FSH is surging, trying to ask the ovaries for an egg, and then all of a sudden the ovaries kick into gear and you get this sudden surge, the sudden increase in progesterone as the egg releases and then also estrogen. But that egg usually is not as high quality. So the progesterone levels, they may be very normal at first, but they tend to fall off earlier. And then also the estrogen does fall down. So you have, people like to think about hormone balance and they think of it as a scale. But really, it's more of a very well-planned roller coaster. But now you have these much higher peaks and dips, and that's what causes the symptoms that people start to wonder, am I in perimenopause? Eventually, that does stop, though. Usually lasts about 7 to 10 years. Perimenopause with this roller coaster. And then all of a sudden, that will just stop one day. So then the estrogen does decrease to very, very low levels. There are some things that raise estrogen separately from your ovaries, but in general, the estrogen is very low. The FSH continues to be high because it's still asking the ovaries, do we have an egg left? And that is the kind of remaining stage of the rest of the woman's life, and slowly the FSH will kind of decrease as the body gives up and transitions.
So how would someone know, oh, I'm definitely in perimenopause? Do you have to be a certain age? Is it purely symptom-based? Are there labs to say I'm in perimenopause? And then we'll also do the same for menopause, right?
Yeah. So in perimenopause, those symptoms typically start in the 40s or early 40s. And I always say there's kind of different ways to figure out what the definition is and if you meet the standard. And one is by time. So that is, perimenopause tends to last about 7 to 10 years before menopause happens. The average age of menopause is 52. So if you have hit 43, 44, 45, by the time definition, you are most likely in perimenopause. Some women they know my mom was 56, and there's this genetic component. So you may know time definition-wise that you won't enter that till a later stage. Most women, it's just not that clear, though, and it's more symptom-based. The very first symptom of perimenopause typically is a sleep disruption.
Okay.
That's actually caused by that drop-off in progesterone as the egg quality decreases.
Okay.
Also, strangely enough, the cycles will shorten in length. So then here's the other definition of perimenopause that applies to most women, which is a cycle change.
Cycle change, no matter what?
Right. Most typically, and the most easy to determine is irregularity when you had a previously regular cycle. However, there's many hormone imbalances that can happen throughout a woman's life that can also be confused here. So you are looking for someone who's had very regular cycles, and then all of a sudden, age 41, 42, they become less regular. Another thing that can happen is the cycles shorten or lengthen dramatically in comparison to what was normal for you before, or the bleeding changes. You had always had very moderate bleeding. Now all of a sudden it's incredibly heavy. Or conversely, now extremely light. So those are more common ways to determine, and it's still, you're excluding other reasons that those could be happening. If everything else checks out and this change persists, more than likely it's a sign of perimenopause.
What if you had really irregular cycles, even just leading into perimenopause? Does that just essentially make it even harder to diagnose?
Yeah, so a lot of times there's reasons for that we already know about or that you can find as you go in, but a lot of times they'll have other changes. Like, for example, they've always had very, very irregular cycles, but their bleeding's been heavy, but they've never had 4 to 6 months between cycles. And now they're having hot flashes in between, which is a major sign that there's something hormonal going on with estrogen. Or they, for example, like a PCOS labs, it's always kind of shown PCOS, but now all of a sudden the FSH is creeping up. So the FSH, that signaling hormone, if you can catch it, which is very difficult to do because these labs in perimenopause are all over the place from day to day. But if you see a high FSH, the only reason for that to be high is the body is looking for an egg, and that's a decreased supply.
You mentioned just in terms of symptoms. So you mentioned sleep disruption, hot flashes. I think everybody knows about that one. And what are maybe some other symptoms that are maybe a little more nuanced that could be pointing towards maybe this is a hormonal perimenopause going on?
Most common symptom is brain fog, which can be very tricky because there's many, many reasons, viral, bacterial, metabolic, many reasons for brain fog. Other things that can happen is the libido can change dramatically. Sometimes that, has been normal a woman's entire life, and now all of a sudden she just can't respond to her husband. Sometimes there is a migration of weight and fat storage to the abdomen. So women have been a stable weight for years, and then all of a sudden, maybe the scale hasn't even changed, but their pants don't fit.
Okay. Fascinating. Okay, so that would all be like, maybe we need to think about hormones. Now, next step, is it, great, we're going to, and you kind of touched on this a little bit, we're going to run a bunch of tests and we're going to know for sure that you're in perimenopause, or it's a little more nuanced. Do we run tests on it? Is it worthwhile when you do run tests? Like, what is the best test to run and when? Yeah, what's your approach?
Yeah, so lab tests are very tricky and controversial in both the perimenopause and menopause space. Menopause is so much easier because there is a clear lab pattern that can help determine that more than likely you're in menopause, which you use also with the menstrual history. But in perimenopause, a lot of times those labs are normal. In fact, this is the main frustration with women when they're care providers, because the official answer from all of the governing bodies, whether that be ACOG, whether that's the North American Menopause Association, is that labs are not needed in identifying problems with hormones, other than like large problems like premature ovarian failure. But what you can see is if you are aware of your cycle and you do know how to time those appropriately, sometimes you can catch some of the imbalances that happen. So, for example, if it's a cycle day 3 to 6 and your estrogen is, less than 10, I would consider that pretty abnormal, because if you're still cycling regularly, your body should probably be responding a little bit more. So timing them with the cycle, with a very, very detailed history, labs alongside a symptom journal can be very, very helpful, because that symptom journal usually paints a very clear picture of what hormones are low and what hormones are high. And if you have the exact numbers there beside them, you can match them up and you can have a good clear picture that this is more than likely what's going to help.
Yeah. And I think too, I'd love to know if you find this, but especially in hormones, like it's hard with just a one-time shot. A lot of times it's like, okay, if we trend this and we can see that you're trending a particular way, because we don't know what your estrogen was 4 years ago when you were cycling normally and when you felt great, and it might have been on the higher end in general. And so now, we're just catching a kind of this one, especially if we're just coming in now.
Yeah, one moment in time.
Yeah, exactly. We're trying to catch what it is, but sometimes we need to then repeat to see what's happening over time, right?
Right. Yes, this is where it can be really helpful for women, especially who like to see their numbers on paper, because if you trend those labs, particularly every 3 to 6 months for the next 4 to 5 years, you will see yourself progress through the menopause transition. That estrogen may decrease. It may increase, because that's also part of it. The progesterone tends to decrease and the FSH slowly rises.
What about testosterone?
So testosterone is a great conversation.
A podcast in itself,
yes,
probably.
Again, also very, very controversial.
Yeah.
Oftentimes benefits women, especially in perimenopause, a lot. As a country, we don't have all the data for women, but we have a lot of this data for men. Our hormones have decreased a lot over the last 40 years just in response to our lifestyle and the things that we have been exposed to, pesticides, all the things. So for example, for men, if you tested a man of the exact same age in 1970, his testosterone would be about 40% higher than a man of today. And I think you can kind of extrapolate that for women. It's similar, but we don't have that data because no one was interested in testing a female's testosterone. Yes.
Shocking.
So it's a crucial hormone, though. It's kind of the zest for life hormone. It really helps with libido. It helps with muscle mass. Some women do have incredibly low testosterone. You can pick that up on labs. It matches symptoms. It's very straightforward. However, a normal testosterone level, which is very wide range, I believe we don't really have good information in setting that level right now at this time. But a normal testosterone level, most providers wouldn't take another look at it, but it doesn't mean that you wouldn't feel better or treating that testosterone to bring it closer to where it was, maybe before you had your children, wouldn't really be helpful with your health.
We kind of glazed over this, so I just want to make sure we capture it. How would you define, how do I know I'm now out of perimenopause and actually into menopause?
Yes. So menopause is actually one day. It's the day that you go 365 days without a period.
Just one day. That's it.
Just one day. After
then it's
that,
over.
You are post-menopausal. You have had that day.
Okay.
Which is very tricky because one of my most common questions is, I just had my period. It has been 13 months.
Right.
Sometimes periods don't read the textbook.
Yeah.
But in general, once you have had that full year without cycles, they will not restart. This is, again, tricky with people who have had PCOS or weight influence menstrual suppression, because those are sometimes the people that
will go 13 months.
Exactly. But in general, that's how you know.
Okay, great. And when menopause happens, you touched on this a little bit, but basically all your hormones, like in my head, they're just like gone, which is probably not true. But what happens from that roller coaster of perimenopause? Then is everything just stable and it's never going to change again? How does that work?
So estrogen, it kind of depends on body mass. Your fat tissue is a major producer of estrogen. So your estrogen may be present somewhat, but it's generally very, very low. Testosterone's a little different. That one is not as dependent on menopause. It tends to decrease slowly and evenly throughout your life. Progesterone is gone. And then FSH, that one is generally high for some time.
And then, so, obviously we talked about, I think I'm in perimenopause. We have patients who are like, I think I might be in perimenopause or menopause. We talked about testing. Cycle day specific is really helpful, trending over time. But ultimately, if we're seeing the symptoms, your history is aligning with perimenopause, then no matter what the labs say, we can diagnose it as perimenopause. Is that correct?
Yep, that's right.
Okay. And then what would you say in terms of, treatment? What are some diet and lifestyle things that might help? But also, what are some other things that we can do, like HRT?
Yeah. So I like to think about health in the perimenopause era as kind of having a couple different pillars. One is your mind, your brain health, mood. One is your heart health, which is actually the center and the core of everything. Metabolism and strength, and then pelvic floor health. All of those things, there are many, many lifestyle interventions. The most powerful one is weight training. In fact, I always tell my patients, there is no hormone that I can give you that is going to do as much for your body as weight training will. In only 8 minutes a day, you can actually have noticeable improvements on most health outcomes, including, dementia and heart disease, which is incredible. Who doesn't have 8 minutes that they're, hanging out between activities that they could do a little bit of weight training? So diet can be very, very helpful. A lot of times women need to shift how they eat. If they've been able to maintain good carb intake throughout their childbearing years, that need usually cuts back a little bit. Their fiber needs may increase. Their fat intake becomes even more important for regulating their metabolism. So when those things start to break down at the point when lifestyle alone is not, or you feel too bad to be able to implement those changes, you don't feel like weightlifting, your brain fog is stopping you from being able to even get your life to the point where you have time for that. At that point, HRT can be very helpful. I always think of it as supporting all of those other pillars. And for each one, it does have a huge ability to contribute and to maintain health.
And HRT is hormone replacement therapy. And that's obviously a huge, big, hot topic, I would say. What are you typically doing in terms of delivery method? Then what does implementation look like? And what are some of the symptoms that it helps with?
Yeah, so estrogen is having this huge resurgence in the understanding that transdermal estrogen does not carry a lot of the risks that oral. So people who would be not candidates for taking oral, maybe they've had a blood clot in the past, or they have concerns about those other side effects of oral estrogen, which are low, but present and contributed to the fear that has been shown in the past. They're realizing that they're candidates for transdermal estrogen. Testosterone is also transdermal or vaginal. Both estrogen and progesterone and testosterone cannot be delivered vaginally. And then progesterone, most of the time for most women, have the best benefits
orally. And by transdermal, you mean like a lotion?
Lotion or a patch or a cream.
Mm-hmm.
Sometimes gels.
Mm-hmm. Awesome. And that's like you're doing it once a day, twice a day. What does that look like?
Yeah, so with a patch, which most women tend to start with patches. It's kind of convenient because it's only twice a week. Most of the other creams are about once a day.
And is it like I put a little bit on my wrist? Or like how do you put the cream on?
Usually a little bit more of maybe inner thigh, inner arm, somewhere that's not going to be directly having that rub off, kind of gently massaging it in.
Okay, awesome. And then tell me a little bit about like what's some of the fears and pushback and maybe misconceptions about hormone replacement therapy that you've seen, and maybe speak to the top ones.
Yeah, so there's definitely a concern with hormone replacement therapy and breast cancer because of a progestin, which is a synthetic progesterone that's in the past been given with estrogen. It does raise the chances of breast cancer. That fear became projected onto estrogen itself because those were studied together. Also a fear of blood clots and strokes because oral estrogen does increase the clotting threshold, which usually you can figure out if that's going to be a problem with a history. You know, if that person has had a pregnancy without any complications, those levels of estrogen are much, much higher. But that person would still potentially be a candidate for a transdermal estrogen through the skin.
And what about weight loss? Like, do you expect, what symptoms would I expect to help when I do start HRT? And maybe what are some that it's not going to help?
So in general, women gain about 7 pounds through the menopause transition and then a half a pound every year after that. Mm-hmm. And estrogen does do a lot to help reverse insulin sensitivity. So a lot of people are hopeful that they will lose weight when they get on HRT, which can happen indirectly. Some women see about a modest 3 to 5 pound weight loss at the beginning, but they can also gain that much in water retention, especially if you're on progesterone, which isn't truly weight. It's water weight. But over time, indirectly, again, by supporting weight training, supporting good nutrition, it definitely helps slow and prevent the accumulation of more weight gain.
Okay, awesome. Love that. And what about kind of the question of like, am I too young to possibly need to look into this?
Yeah, it is amazing. I believe with just our lifestyle and everything, women are coming younger and younger with symptoms that are classic for menopause. Their sleep is poor. They're having hot flashes, especially around the cycle. It is a lot more tricky to find your right dose, and you need many more adjustments when you're younger because you are making a lot of your own hormones. But I have seen women as young as 35 need estrogen support at particular times of their cycle, which I do believe is just because of the modern world that we live in.
Yeah, absolutely. And then, once you start someone on HRT, is this a lifelong commitment? Is it something they can come off of? what do you see most commonly?
Yeah, so a lot of times it is a longer term treatment because if it works for you, you are going to feel really, really well, and your body was designed to need that hormone. That being said, some women just need it through this roller coaster to stabilize. And then they do, especially if they don't want to be on hormones, they are able to wean off. So they're just helping balance that roller coaster. But it used to be the recommendation that you stayed on hormones for only 5 years post-menopause, but that was actually a recommendation based on a lack of evidence, not that we have actual evidence that it was actually bad or causing harm at that point. And we do have now the very first long-term studies that show people who do stay on it long-term have reduced all-cause mortality, meaning it doesn't matter what cause of death you're looking at, people who are on estrogen long-term do better and outlive that.
That's so interesting. I love it. I love that we have the long-term data now. And I know it's still like limited, obviously. I mean, but it's definitely something worthwhile if you're feeling really great, you know?
Right.
It's nice to know that like we can push the limit a little bit more because we have the evidence to back it. So I think one thing I love when we first talked is that you said, all these women are suffering so much and it's so needless. And I think that's really, when I think of perimenopause and menopause, is like there is something that we could do to help you. Like, yes, there is diet and lifestyle, absolutely. But I know I've seen in my own patients, a lot of times that's just not enough and you're really miserable and life is really hard and you're juggling kids and your marriage and work and then this roller coaster of perimenopause comes in and it feels like, you know, everything's just hit the fan. And it's like we have tools that are safe and effective to help you. And so I think that's one thing that I love about your approach is really just this heart for like, let us help you feel your best so that you can serve your family and, you know, be present.
Yeah, I just think it's amazing because women do really have so much to give. We're kind of the core of our families. We are the core of the transmission of culture even. One of the theories of why menopause even exists is called the grandmother theory. And it's that the grandchildren do so much better when they have a woman who is free from her own children and just able to devote her time and attention towards caring for these children. Women have so much to give in their marriages and in their communities. So when the hormones begin to really get in the way of that, I just feel like I can give them this gift where they can go back out and continue to give and preserve this amazing role that they have.
So beautiful. Well, thank you so much, Sarah, for sitting down with me and telling us, imparting all of your wisdom on hormones. And I'm so excited that you're part of our team. And if anybody, you know, needs you, then obviously feel free to reach out. Thanks, Sarah.
Thank you.
Thanks for listening to this week's episode. To learn more, you can visit our website at fiathealth.org. If you enjoyed this episode and you'd like to help support the podcast, please subscribe to our show on your favorite podcast platform and leave us a review. This helps make the podcast easier to find. Lastly, if you'd like to reach out, ask a question, or suggest a topic for a future show, send us an email at media@fiathealth.org. God bless.